So, good afternoon. First of all, I would like to thank the organizers for giving us the chance to present the Satellite Symposium. And I would like to thank Dr. Jehan for this talk. Just to follow on Dr. Jehan's talk, she highlighted on EMPA-RIG, and tonight I will have a virtual sort of talk on more emphasis on EMPA-kidney trial. So, but with now we're going to talk about a fascinating group, GLP-1. This morning, Dr. Ahmed Hassoun highlighted in details about all the GLP-1 agonists, and here we're going to go more in depth looking at oral semaglutide. We know about diabetes prevalence is really increasing worldwide, and Middle East and North Africa is expected 96% increase by the year 2045. And we know in Bahrain itself, the prevalence is estimated according to the IDF data from 2021 about 15%, but I believe it's even higher than 15%. And the estimation worldwide, especially for the Middle East and North Africa region, is that by 2045, we're going to have like 135 million people affected with type 2 diabetes. That means that 1 in 6 adults has diabetes. This is like the highest proportion of all IDF regions in terms of the Middle East. And it has the highest percentage, like 24.5%. And the diabetes expenditure in the Middle East and North Africa region totals about $33 billion in 2021, and it's responsible for more than 700,000 deaths in 2021. We know that poor glycemic control is due mainly to therapeutic inertia and failure to intensify therapy in a timely manner. There are several factors that affect the therapeutic inertia. These are physician-related, patient-related, healthcare system-related. And in one of the studies, it was shown that in people with type 2 diabetes who had poor glycemic control, HbA1c above 7%, it took physicians on average almost 3 years to intensify oral antidiabetic agents, and it took them 7 years for injectable intensification, whether it be GLP-1 or insulinization. So looking at GLP-1 as a class, a fascinating class, not only in terms of glycemic control, their control goes actually beyond optimal glycemic control. So in addition to the well-known effect of the weight loss that they are popular for, they are very effective in managing hyperglycemia in early stage, as we know, minimal risk of hypoglycemia, improvement in cardiovascular risk factors, enhancement of patient adherence to antihyperglycemic drugs, and beneficial beta cell salvage in early stage type 2 diabetes. So semaglutide as a molecule, it has a 94% similarity to the human GLP-1 with a T-half of 1 week. And with the amino acid substitution, it protects it from the quick degradation by the DPP-4. And it demonstrated really clearly in the clinical trials its safety and efficacy. But it is combined with the SNAC, which is the sodium N-hydroxybenzyl caprylate. This is an absorption enhancer, so it increases the bioavailability of the oral administration of the semaglutide, and the SNAC actually causes increase in the pH, so it protects the proteolytic degradation and facilitates absorption of the molecule across the gastric epithelium. So it has been always a challenge to develop oral peptides because of the challenges are mainly due to quick degradation by the stomach, the low pH and proteolytic enzymes, limited permeability across the GI epithelium, and also that the GLP-1 administration alone has a very low oral bioavailability. But Novo did it with one of its kind and the only one now approved oral GLP-1 agonist therapy because of the effects of the SNAC, which is strictly time, molecular size, and concentration dependent and fully reversible. Approximately 1% of semaglutide is absorbed by this technology. That's why it's very important that we give this medication with a very, very special instruction to our patients. It's like rituals I tell my patients that you need to do. You wake up first in the morning, fasting on empty stomach, taking the semaglutide tablet with a glass of water, or if you want to be really precise, you can say 120 ml, a glass of water. Wait for 30 minutes before eating or drinking, and then a patient can have their first drink or meal. And the usual starting dose is 3 milligram once a day for 1 month. Then you can increase the dose depending on the desire that you want in terms of glycemic control, 7 milligram daily for 1 month, and then you can take the patient to the highest dose, which is 14 milligram daily. It has been shown from the trials that oral semaglutide is very safe in terms of hepatic impairment at different stages of liver disease. There is no need for dose adjustments. Similarly, in patients with renal impairment at different stages of renal impairment, including end-stage renal disease, there is no need to do any dose adjustment for oral semaglutide. Dr. Ahmed Hassoun this morning highlighted the results of these studies on oral semaglutide along with other GLP-1 agonists. So the Pioneer 1, 5, and the 7 and 8, it was a clinical trial conducted on oral semaglutide at different doses, 3 milligram, 7 milligram, 14 milligram. In terms of efficacy, a study looking at the HbA1c reduction and also looking at the effect on the weight. So Pioneer 1 was basically monotherapy, and it looked at semaglutide at different doses compared to the placebo. As you can see, significant reduction in HbA1c from baseline, reaching to 1.4% for the higher dose, 14 milligram. In Pioneer 2, it was compared versus empagliflozin. Again, it did better than empagliflozin in terms of glycemic control. Similarly, with versus sitagliptin, significant reduction. There was a difference with liraglutide, but not statistically very significant. But again, looking at Pioneer 5, 7, and 8, 8 was on top of insulin therapy. Again, significant HbA1c reduction reaching to 1.2% from baseline. Now, what about change in body weight? So again, Pioneer 1 compared to placebo, really significant. The weight loss range from between 1.5 to 3.7 kgs, so for the higher dose. Similarly, in Pioneer 3, compared with sitagliptin, significant reduction, and also in patients with insulin treatment in Pioneer 8. In Pioneer 2, you can see with empagliflozin, it didn't meet really statistically significance, but at 52 weeks, when they did the trial product estimate, it showed that the oral semaglutide actually did very well in terms of HbA1c as well as weight reduction versus empagliflozin. Now, when you look at oral semaglutide as an oral anti-diabetic agent compared to the other oral anti-diabetic agents available, so you can see to the left Pioneer 2, when you compare it to the SGLT2, when you want really looking for efficacy, you want to have more powerful HbA1c reduction, you can see that oral semaglutide did better than empagliflozin 25 milligram. And in terms of Pioneer 3 for the sitagliptin, again, oral versus oral therapy, again, you can see that even, as you can see here, even the lower doses, we are not even talking about the higher 14 milligram. The 3, 7 milligram doses, 7 milligram did better in terms of glycemic efficacy compared to sitagliptin. And in terms of body weight, we mentioned about empagliflozin was not statistically significant change, but with sitagliptin, yes, you can see that with higher doses, the weight loss reached up to 3 kgs loss from baseline. So when we look at the pioneer trials, there were no serious significant adverse events reported across these trials compared with the comparators. And in summary, when you look at all these the pioneer trials, you can see that in terms of glycemic control, oral semaglutide was superior versus empagliflozin and sitagliptin, non-inferior versus liraglutide. In terms of weight, oral semaglutide was superior versus sitagliptin and liraglutide, but no difference with empagliflozin. And at the end of the trial, as we can see overall, significant reduction in HbA1c and weight reduction versus sita, empa, and liraglutide. What about cardiovascular safety? In Pioneer 6, actually, it showed that it is non-inferior. There was no any cardiovascular safety concerns. There were no superiority. It did not report superiority, but the trial was really halted because they have reached to the data that they wanted to reach in terms of non-inferiority. But if the trial was extended, we don't know if the results would have shown some superiority effect, but we know it's cardiovascular safe. So overall, safety, oral semaglutide was well tolerated with a safety profile consistent with GLP-1 agonist class, and the most common adverse event in the trial was some GI side effects like moderate nausea. Now, OSEMA of FAST trial was a prospective study, and it was a non-interventional study investigating primarily the glycemic control and also other secondary outcomes, looking at oral semaglutide specifically during the month of Ramadan, and it was conducted in UAE, Saudi Arabia, and Kuwait. The primary objective was efficacy, so looking at the glycemic control associated with the use of oral semaglutide in type 2 diabetes during Ramadan, but secondary objective was to assess so many things like weight control, dosing compliance, safety parameters. So again, the primary efficacy was, the primary endpoint was change in HbA1c. The secondary endpoint, absolute and relative change in body weight, self-reported hypoglycemia or hyperglycemia hospitalization, GI side effects, and change in concomitant oral agents. Of course, these were strictly followed in terms of change in oral semaglutide, waiting time, intake of oral, intake with water, and timing of the intake of oral semaglutide. The study the inclusion criteria, of course, type 2 diabetes and 18 years and above, but very important that the oral semaglutide should have been at least 4 weeks on maintenance dose with or without other agents. Now, when we look at the demographic characteristics of the study, we can see that most of the patients actually had a BMI more than 30, about 62% of the patients. And you can see that in terms of the HbA1c enrollment, most of them actually were below 7%, and 57% were HbA1c 7 to 8%. And when you look at the fasting status pre, during, and post-Ramadan, you can see that, of course, most of the patients were in the non-fasting before Ramadan, and 85% of patients were fasting during Ramadan. Now, the timing of the intake of the oral semaglutide pre, during, and post-Ramadan, you can see in pre-Ramadan, it was early in the morning after waking up. In Ramadan, it was changed at iftar time in 72% of patients. 24% were taking it at suhoor, and then post-Ramadan, 86% of the patients were back to the original at breakfast time or early in the morning. So the results of the study showed a significant reduction in HbA1c. This study was across 20 weeks. So the 8 weeks pre-enrollment, pre-Ramadan, then during Ramadan, and then 8 weeks following Ramadan. So there was about 2% reduction in HbA1c from baseline at the time of enrollment, and there was a significant reduction in weight, reaching up to average 5 kgs from the time of enrollment to the end of Ramadan. in terms of the hypoglycemic events, the reported rate of hypoglycemia pre-Ramadan was 9%. It was, slightly increased during Ramadan to 24% and then back to 10% after Ramadan. But all these reported hypoglycemic side effects were very mild. Nothing, no serious hypoglycemia. So the conclusion of the, it interrupted me. Can I go back? Just have one more slide. Yeah. So this is the final slide. So these are the ongoing semaglutide trials. So we have the SOUL trial, which is probably estimated by this year. The results will be out on oral semaglutide, cardiovascular outcome in patients with type 2 diabetes. This morning we talked about FLOW study that was terminated because it seems of early positive side outcomes. The SELECT trial already out for the sub-Q semaglutide 2.4 showed positive cardiovascular outcome in patients with overweight and obesity. And we have the remodeled trial. It's a mechanistic renal sort of trial to detect the biopsy changes in the renal parenchyma with the use of semaglutide. OASIS trial was out, and it showed in OASIS trial oral semaglutide of higher doses, 50 milligram daily, was tested in patients without diabetes to see their effect on weight loss, and it caused actually significant weight loss, 15% to almost even in some subjects reaching to 34%. So I think Novo is going to use this trial to file for approval for oral semaglutide as an anti-obesity medication. So we have one oral anti-obesity medication coming in the horizon. So again, in general, oral semaglutide, the first oral GLP-1, it has established safety cardiovascular profile, powerful glycemic control, and powerful weight loss agent. Thank you very much for your attention.